Hi, good morning, friends. I want to bring one more common and very common and very important topic. Although definitely it is a bread and butter, or we can say it's a very common case handled by any neurosurgeon in the world, but simultaneously it's an important to know each and everything about it, and sometimes you are getting in the dilemma, so we have to understand each and everything. First of all, I want to discuss here the most important thing or the topic is the epidural hematoma. As you know, the epidural hematoma, we all know very well by the name. We recognize it very much, and in that regard, the I want to take one case like an analogy, and then we will discuss in detail, so we can correlate our patient with the details of the extradural or the epidural hematoma, and we can understand and how we can apply our knowledge for that. So it's me, Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. So a 48-year-old woman fell from the third floor of a building, and she present with the Glasgow Coma scale score of 7, and the patient is hemodynamically stable, and she is quickly intubated. Her pupils are both reactive but asymmetrical. So the few questions arise here, and we will try to answer these questions, and simultaneously we will discuss this topic in little detail. As you know, there is a linear non-displaced temporal bone fracture with underlying pneumocephalus. Actually, I want to explain in front of you. This is a CT scan we did for that lady, and the CT scan suggested there is a linear undisplaced temporal bone fracture with the underlying pneumocephalus, and there is also a hyperdense lesion in the temporal and temporoparietal area on the same side of the fracture. The lesions are biconvex, means lens-shaped, and are complete with an epidural hematoma. The lesions are causing a midline shift of 0.7 centimeter and a right-sided uncal herniation. As you know, the extradural hematoma are usually located in the temporoparietal area. Posterior fossa hematomas only represent 5% of extradural hematoma, and the source is usually the meningeal artery, which is the most commonly middle meningeal artery, but sometimes this can be bleeding vein or another lying sinus. It can cause extradural hematoma. The bleeding in the epidural space will strip the dura from the skull and causing mass effect and raising intracranial pressure. Approximately 85% of cases will be associated with skull fractures, and 20% of patients will present in the comatose state. Other presentation include localized neurological finding and confusion. The classical presentation of treatment improvement followed by the sudden deterioration occur in 47% of admission, which is called the lucid interval. Our initial management for this patient, once the airway has been secured, as I mentioned, the patient was intubated quickly, and the patient is hemodynamically stable. She needs to undergo emergency evacuation for the hematoma, and the patient should also be loaded with an anti-epileptic drugs. Infusing mannitol and hyperventilation may be done as temporary measure before the evacuation. This is a surgical emergency because there is a symptomatically significant mass less than 1 centimeter with midline shift less than 0.5 centimeter. So there are the criteria for the surgical evacuation. An extradural hematoma with volume more than 30 cubic centimeter, regardless of the GCS score. The patient with the GCS score above 8 and a hematoma less than 30 centimeter per cubic and less than 15 millimeter thickness and 0.5 centimeter midline shift and without focal deficit can be managed by close observation with serial scan and placement in a monitored neurosurgical unit. And we did the same thing in our patient. Outcome, depends on the many factors, for example, GCS score, CT scan finding, age, timing of surgery, and the presence of the other lesion. The overall mortality for the patient who underwent surgical evacuation is 10%. The faster the evacuation is done, the better will be the outcome because the neurological status prior to the surgery is the main determinant of outcome. Extradural hematoma evacuation is considered one of the most cost-effective surgical procedure of all in terms of quality of life. So it is not all about the, we can say, the epidural hematoma, but it is some guideline, and I just wanted to present my case and in that manner so we can understand the analogy for the epidural hematoma. As we know, the epidural hematoma is an extraaxial collection of the blood within the potential space between the outer layer of the dura mater and the inner layer or the inner table of the skull. It is confined by the lateral sutures and especially the coronal suture where the dural inserts. It is a life-threatening condition which may require immediate intervention and can be associated with significant morbidity and mortality if left untreated. Rapid diagnosis and evacuations are important for a good outcome. It occurs in approximately 10% of traumatic brain injury, require hospitalization. Both traumatic and non-traumatic mechanism can cause in epidural hematoma. The majority of cases related to the traumatic mechanism are a result of head injury due to motor vehicle collision, physical assault, or accidental falls. Non-traumatic mechanisms include the following: infection, abscess, coagulopathy, hemorrhagic tumor, vascular malformation. All epidural hematoma occur in 2% of all head injuries and up to 15% of all fatal head traumas along this. So the male are more often affected than are female, therefore the incidence is higher among the adolescent and young adults. The mean age of affected patient is between 20 to 30 years, and it is rare after the 50 to 60 years of the age. As an individual age advances, the dura mater become more adherent to the overlying bone. So this decreases the chance that the hematoma can develop in the space between the cranium and the dura. Actually, the arterial injury, according to the pathophysiology, the most epidural hematoma result from the arterial bleeding from the branch of the middle meningeal artery and the anterior meningeal artery, or the dural intravenous fistula at the vertex may be involved. So up to the 10% of the extradural hematoma are due to the venous bleed, and following the laceration of the dural venous sinus. In adults, up to the 75% of the extradural hematoma occurs in the temporal region. However, in children, they occur with the similar frequency in the temporal, occipital, frontal, and posterior fossa region. The skull fracture is present in the majority of patients with extradural hematoma, and these hematomas often present beneath a fracture of the squamous part of the temporal bone. If this condition occurs within the spine, the entity is described as spinal epidural hematoma. Based on the radiographic progression, it can be classified into one of the following. Type 1, which is called acute, occur one day and associated with the swirl of unclotted blood. Type 2 is a subacute, occurring between 2 to 4 days and usually solid. And third one, which is the chronic, occurring between the 7 to the 20 days, mixed or lucent appearance and with contrast enhancement. The typical presentation is an initial loss of the consciousness following trauma, a complete transit recovery, often termed as a lucid interval, and culminating in a rapid progression of neurological deterioration. This occurs in 14% to 21% of patients with the extradural hematoma. However, these patients may be unconscious from the beginning or may regain consciousness after a brief coma or may have no loss of consciousness. Therefore, the presentation range from the temporary loss of the consciousness to a coma. Be aware that the lucid interval is not a pathognomonic for the extradural hematoma and may occur in patients who sustain other expanding mass lesions. The classic lucid interval occur in pure extradural hematoma that are very large and demonstrate CT scan finding of active bleeding. The presentation of symptoms depends on how quickly the extradural hematoma is developing within the cranial vault. A patient with a small extradural hematoma may be symptomatic, but this is rare, and also an extradural hematoma may also develop in a delayed fashion. A posterior fossa extradural hematoma is a rare event, and this kind of the extradural hematoma may account for approximately 5% of all post-traumatic intracranial mass lesion. So the patient with the posterior fossa extradural hematoma may remain conscious until late in the evaluation of hematoma, when they may suddenly lose consciousness, become apneic and die, and this lesion often extend into the supratentorial compartment by stripping the dura over the transverse sinus and resulting in significant amount of the intracranial bleed. The enlarging hematoma lead to eventual evaluation of intracranial pressure, which may be detected in a clinical setting by observing ipsilateral pupil dilatation secondary to the uncal herniation and oculomotor nerve compression. The presence of elevated blood pressure, slowed heart rate, and irregular breathing, this triad is known as the Cushing reflex, and this finding may indicate the need for immediate intracranial intervention to prevent central nervous system depression and death. Imaging studies such as the computerized tomogram can comprise the mainstay of the diagnosis. Laboratory studies such as INR, partial thromboplastin time, and the liver function test may be obtained to assess for increased bleeding risk for underlying coagulopathies. CT scan is the most common imaging modality to access for the intracranial bleeding, and its popularity is related to its widespread availability in emergency departments, and the majority of the extradural hematoma are identifiable on a CT scan. The classic presentation is a biconvex or lens-shaped mass on the brain CT scan due to the limited ability of blood to expand within the fixed attachment of the dura to the cranial suture. Extradural hematoma does not cross suture line, and generally the radiologist uses a standard formula for estimating the amount of the blood present in an extradural hematoma. It is as follows. The maximum, if it is the ABC, they divided by the 2, such as the maximum hemorrhage diameter in the CT slice with the largest area of the hemorrhage, and the maximum diameter 90 degrees to the A on the same CT slice, and the number of the CT slice with the hemorrhage multiplied by the slide thickness in the centimeter. However, other CT findings that may need to be taken into account when evaluating extradural hematoma. For example, continued bleeding may be indicated by the area of the low density or a swirl sign, and the latter may be used for the prognosis and often indicate the need for the surgical intervention. If the extradural hematoma abut brain tissue, that is the hemorrhagic or contuses, it may appear hollow and thus may be overlooked for the CT scan is not carefully examined. Several factors may lead to a non-diagnostic CT scan, and these are as follows. As you know, the low density blood collection may result from the severe anemia, thus leading to the misinterpretation, and the arterial extravasation may be reduced secondary to the severe hypertension, and the positive finding on CT require that the enough blood accumulate for visualization. If the CT is obtained too soon after the trauma, if the CT scan are obtained too soon after the trauma, there may not be sufficient accumulation of appropriate interpretation. If the extradural hematoma is secondary to venous bleeding, then the blood accumulation may be slow. This could potentially result in difficulty with CT interpretation. Magnetic resonance imaging and brain MRI is more sensitive than a CT scan, particularly when assessing of the extradural hematoma in the vertex. It should be obtained when there is a high clinical suspicion for extradural hematoma, accompanying a negative initial head CT scan. In the situation of the suspected spinal extradural hematoma, a spinal MRI is the preferred imaging modality as it offered higher observation versus a spinal CT. Angiography, when evaluating the extradural hematoma located in the vertex, the healthcare professional should evaluate for the presence of the dural intravenous fistula that may have arise from the middle meningeal artery. Angiography may be required to evaluate the presence of such a lesion fully. Angiography is sometimes required, and especially to look the dural arterial venous fistula, and that may have arisen from the middle meningeal artery, and the angiography may be required to evaluate the presence of such lesion fully and completely. Treatment, it is everybody knows, but it's very important we should discuss. Extradural hematoma is a neurosurgical emergency. It therefore requires an urgent surgical evacuation to prevent irreversible neurological injury and death secondary to the hematoma expansion and herniation. Neurosurgical consultation should be urgently obtained as it is important to intervene within 1 to 2 hours of presentation. The priority is to stabilize the patient, including the ABC, airway, breathing, circulation, and these should be addressed urgently. Surgical intervention is recommended in patients with the acute extradural hematoma. Hematoma volume greater than 30 ml regardless of the Glasgow Coma score scale. So the Glasgow Coma less than 9 with pupillary abnormality like Inus cocorea. Operative management if patient with acute and symptomatic extradural hematoma, the treatment is craniotomy, hematoma evacuation based on the available literature. Based on the available literature, the burr hole evacuation is often a crucial form of the intervention. Of more advanced surgical expertise is unavailable. It may be decreased mortality. However, the performance of the craniotomy, if feasible, can provide a more thorough evacuation of the hematoma. On operative management, there is a scarcity of the literature comparing conservative management with the surgical intervention in patients with the extradural hematoma. However, a non-surgical approach may be considered in patients with the acute extradural hematoma who has mild symptoms and meet all of the criteria listed below, such as the extradural volume of less than 30 ml, plot diameter of less than 15 mm, and the midline shift of less than 5 mm, and the GCS greater than 8 on the physical examination show no focal neurological deficit. If the decision is made to manage acute extradural hematoma non-surgically, close observation with repeated neurosurgical examination and continued surveillance with the brain imaging is required, and the risk for the hematoma expansion and clinical deterioration is present. The recommendation is to obtain a follow-up head CT scan within 6 to 8 hours following brain injury. Differential diagnosis such as the intracranial abscess, intracranial mass, seizures, transit ischemic attack. In general, patients with the pure extradural hematoma have an excellent prognosis of the functional outcome after the surgical evacuation when it is rapidly detected and evacuated. A delay in the diagnosis and treatment increases morbidity and mortality. Extradural hematoma caused by the arterial bleeding develop rapidly and can be detected quickly, but those due to the dural sinus tear develop more slowly. Thus, clinical manifestation may be delayed, with the resultant delay in the recognition and evacuation. Generally, an extradural hematoma volume greater than 50 cm prior to the evacuation results in a worse neurological outcome and consequent mortality. So, factors that may influence the outcome are as follows, such as the patient's age, time left between the injury and the treatment, immediate coma or lucid interval, presence of pupillary abnormality, GCS motor score on arrival, CT finding, hematoma volume, and the degree of the midline shift, the presence of the sign of the active hematoma bleeding or associated with intradural lesions. Post-operative treatment are the several markers that correlate with the poor prognosis of the extradural hematoma include the following: the low GCS before surgery or on arrival, abnormal pupil examination, in particularly non-reactive pupil, unilateral or bilateral, advanced age, a time between the neurological symptoms and surgery, elevated intracranial pressure is the most operative period. Certain head CT scan finding can correlate with the poor prognosis. Hematoma volume of greater than 30 to 150 ml is also the poor prognostic indicator. Midline shift more than 10 to 12 millimeter, swirl sign indicate then active bleeding. Associated intracranial lesions such as the contusion, intracerebral hemorrhage, subarachnoid hemorrhage, and diffuse brain swelling, also a very, very important thing. Complications such as the mass effect, compression of the brain if bleeding is significant, herniation, seizures. Following services should be immediate consulted as the outcome in the time dependent trauma surgery, neurosurgery. So The extradural hematoma is a neurosurgical emergency. Suspect extradural hematoma if there is a history of the head trauma leading to the period of the loss of consciousness. Patient with the small extradural hematoma may be asymptomatic, generally occur with the skull fracture, but may occur without a bone fracture. Extradural hematoma does not cross suture lines, although lucid interval is commonly described but non-pathognomonic and may occur in patients with the expanding mass lesion. Patient with the extradural hematoma may be unconscious, may regain consciousness after a brief loss of the consciousness, or may have a no loss of the consciousness. Patient with a small extradural hematoma may be asymmetric, and if rapidly detected and evacuated, the functional outcome is excellent. So, how we can enhance our services for the extradural hematoma is a relatively common presentation to the emergency department, and if not diagnosed associated with the high mortality, the condition is best managed by interprofessional team that include the emergency room physician, the trauma team, radiologist, neurologist, neurosurgeon, intensivist, and ICU nurse. The condition has been associated with the mortality rate in excess of 15%. The key prognostic feature is of level of consciousness at the time of presentation. Both bilateral epidural hematoma and posterior fossa epidural hematoma carry a very high mortality, and the key to treating this condition is preventing it in the first place. Healthcare workers should educate the people on the importance of the head safety equipment when playing sports or while working. So that's all for the extradural hematoma. Also, it's a very, very important and common topic. I wanted to put some light by this lecture. I hope you like it, and thank you so much for listening. Please share, like us, and appreciate us. Thank you so much.